Okay, thank you very much. Uh, Good afternoon, everyone from Ethiopia and Ghana. Welcome. This is Zalalam Getaun, intensivist from St. Paul Hospital, Addis Ababa, Ethiopia. I'm very pleased to chair the webinar from this Global Critical Care uh, Fellowship Seminar Series 2025. Uh, as you know, the decision to give fluid is a big issue at the bedside for all physicians, and to get a good balance between not inducing fluid overload and also making the patient to be hypoperfusion. So after this webinar, we will have the right key for this daily deal. So in this webinar, we will have an opportunity with our international experts to discuss on the fluid responsiveness methods and strategies. So I will try to introduce Dr. Sergio, uh, who is, sorry. So Dr. Sergio, an anesthesiologist and critical care physician, currently serving as assistant professor at Virginia Commonwealth University Health System. After anesthesiology residency, he completed a dual fellowship in transplant anesthesiology and surgical critical care at St. John's, no, at John Hopkins University Hospital. And Dr. Sergio expertise lie in abdominal transplant, anesthesia, perioperative care, and surgical critical care of post-trauma, post-transplant patients. Throughout his career, Dr. Sergio had made contribution to the field of liver transplant anesthesia, transthoracic echocardiography, enhanced recovery after surgery protocol, hemodynamic monitoring, and perioperative fluid management. So Dr. Sergio is actively involved in teaching and mentoring residents and fellows, contributing to the development of next generation of anesthesiologists. He has multiple publications, out of which left ventricular geometry and cardiac function, standardizing of intraoperative uh, intraoperative escalation protocols and postoperative extubation in liver transplant patients are among the few of publication he's having. So welcome, Dr. Sergio. So the floor is open for you. We can continue. So if you guys have any question, you can write or speak through the speaker, or you can forward through the message system, so that we will compile and ask Dr. Sergio. I know you had like a lot of discussion prior to this presentation, and again you are going to have a 1 hour sessions of discussion. So the floor is open for you. Thank you very much.
Thank you for the kind introduction. As you guys might be able to hear, I'm losing my voice. I gave a talk this morning to our grand rounds here. So I'm going to actually do the presentation using pre-recorded audio, but I'll be here to answer questions so that if you guys need me to stop, I'm happy to do that. I can stop in situations when we're reviewing any of the kind of question answer type of situations. So I'm just going to make sure you guys can hear the audio of my presentation. So I'm going to give it a little test here, okay? Can you guys just give me a thumbs up or yes, I can hear the audio? It'll sound a little different than me because my voice is, and this is not my normal voice, okay?
Good day, everyone. I would like to thank you for the invitation to the Global Critical Care Fellows Seminar Series. My name is...
Can you guys hear that audio?
Yes, it's clear and audible.
Perfect. Okay, I'm going to start it over and then we'll get the presentation started. Good enough?
Good day, everyone. I would like to thank you for the invitation to the Global Critical Care Fellows Seminar Series. My name is Sergio Navarrete, and I am an anesthesiologist and critical care physician. I specialize in abdominal transplant anesthesia and critical care. I have no relevant disclosures, but I have a passion for use of critical care ultrasound. The learning objectives for the talk today are the following. Review a brief history of critical care ultrasound. Review current uses of ultrasound in the critical care setting. Explore the evidence basis for use of ultrasound in critical care settings. Okay, so let's get started. First, a little history. On October 29, 1953, after developing M-mode, Elder and Hertz recorded the first cardiac ultrasound images and published their findings in 1954. In spite of its relatively recent discovery, ultrasound technology has progressed rapidly. In 1953, a Swedish cardiologist, Dr. Inge Edler, and a German engineer, Karl Helmuth Hertz, the son of Nobel Prize winner Gustav Hertz, discovered the use of ultrasound technology for diagnostic use. Dr. Edler, of course, was interested in its use for the characterization of cardiac structures. Dr. Edler is known as the father of echocardiography. In the 1970s, 2D echo, Doppler and transesophageal echocardiogram were developed. By the 1980s, development of live real-time images, portability, and probe technology improvement accelerated its adoption into other medical specialties. The FAST protocol was developed in 1989 and then widely used, accepted in the 1990s through the early 2000s. During this time, the American College of Emergency Physicians and American College of Surgeons incorporated the use of ultrasound into practice guidelines. Ultrasound portability and versatility allowed its use in out-of-hospital triage following mass casualty incidents. In the 2000s, ultrasound starts to be used in the intensive care unit. Wernicke and others presented an abstract in 1987 describing the ultrasonographic features of pneumothorax. In 1995, Lichtenstein published one of his first papers comparing the sensitivity and specificity of ultrasound in the detection of pneumothorax. Lichtenstein is responsible for a large proportion of critical care lung ultrasound literature and the creator of the Blue Protocol and Falls Protocol. Over the coming years, rapid improvement in image quality in probes lead to the adoption and acceptance of ultrasound at the bedside by non-cardiologists. Vignon, who, as you will see, is well published in the realm of critical care ultrasound, progressed from stating that transthoracic echo was insufficient for the diagnosis of critical conditions in the intensive care unit circa 1994 to the acceptance and training of non-cardiology residents in 2007. In the mid-2000s, Choli et al. Wrote an editorial advocating for the widespread use of ultrasound in the intensive care unit. In 2009, the American College of Chest Physicians, along with the French equivalent, published practice guidelines detailing the evidence-based recommendation and competence recommendations for critical care ultrasound. In 2015, the Society of Critical Care Medicine also published guidelines and physician training guidelines. A quick note about point-of-care ultrasound versus critical care ultrasound. The guidelines actually delineate expectations for each basic and advanced critical care ultrasound. Echo. Many of you may be familiar with the use of ultrasound for basic coded eyeball test assessment of the heart, also referred to as point-of-care ultrasound. Of those who are anesthesiology residents, the American Society of Anesthesiologists recently endorsed the incorporation of point-of-care ultrasound into residency training, and as you already heard, the American College of Surgeons incorporated ultrasound into its practice recommendations as the FAST exam for trauma patients much earlier. Critical care ultrasound builds upon the basic ultrasound training to evaluate more advanced parameters not often used during a basic point-of-care ultrasound exam. Current uses in the intensive care unit are for procedural guidance, diagnostic cardiac, lung, liver, kidney, and bladder ultrasound, as well as DVT monitoring. Emerging uses are airway, muscle, and central nervous system ultrasound. For this presentation, we will focus on cardiac, thoracic, and volume assessment use cases for bedside ultrasound in the intensive care unit. First, some disclaimers. Bedside ultrasound must be interpreted within the clinical context. Incorporation of situation, temporal acuity change, laboratory data, clinical exam, and critical care echocardiography yield a more reliable diagnosis. I would like to clarify that using ultrasound to assess a patient should not stop the clinician from initiating resuscitative action. The ultrasound assessment of patients should be done simultaneously with bedside physical assessment and resuscitation orders. Critical care ultrasound is for first-line assessment of patients in shock and is for guiding tailored management of unstable patients. It can also be used for monitoring of resuscitative progression. A systematic approach is required to ascertain the correct diagnosis. A single measurement cannot be used as on its own. It may lead to incorrect diagnosis and cause harm to patients. Because of this, many protocols have been evaluated in the literature to systematically assess the hypotensive patient. The Falls Fluid Administration Limited by Lung Sonography Protocol, Free Focused Rapid Protocol Echocardiographic Examination, and the Rush Rapid Ultrasound and Shock Protocol are just a few. The protocol used is not really of importance. The importance is to have a rational and systematic approach. Any value considered on its own, outside of the clinical context, and on its own without the entire picture may lead to errors in diagnosis and treatment. The volume status, fluid responsiveness, and tolerance assessment is only one part of the puzzle. The above study by Gain et al., published in 2015, examined the ability of the Rush protocol to accurately diagnose etiology of shock in critically ill patients. The Rush protocol is one of the most rigorously studied. Cohen's kappa coefficient K is a statistic that is used to describe inter-rater reliability for qualitative categorical items. Okay, let's use a case to guide the rest of the presentation. a 100 kilo, 46-year-old male with a past medical history of constrictive pericarditis, SP, pericardectomy, end-stage renal disease on hemodialysis. He is now. Postoperative day 0 from a video-assisted thoracoscopy for emphysema presents to the intensive care unit for sustained hypotension and hypoxemia in the immediate postoperative period. He is intubated, started on mechanical ventilation, and sedated. He has significant pulse pressure variation, modeling of his lower extremities, and poor capillary refill. His chest tube is to suction, has serosanguinous output, and has a minor air leak. His lactate is 6. His intraoperative fluid balance is plus 1.5 liters, and postoperatively received 20 milliliters per kilogram of isotonic fluid resuscitation. Ask yourself, what is my differential diagnosis, and how can I approach this problem with critical care ultrasound? The differential diagnosis is broad in the post-surgical.
So guys, I just paused the presentation just because I saw some messages in the chat that it might be too fast. Is that correct?
Yes, I mean, for me personally, I think it's hard to follow because it's not going at the normal speed of speech.
Gotcha. I can kind of switch over and just give the presentation the best I can with the voice that I have at the moment. It's not sped up. It's just that's the normal speed that I generally give the presentation, but I can kind of slow down and just try to give it with what I have. So I'll just start from here. It's a good stopping point. We basically just went through the overall kind of introduction, and now we're really getting into the main kind of important parts of the presentation. And I wanted to start with a clinical case. So what do you guys think at this point? How can we use critical care ultrasound to evaluate the patient and then decide whether or not we need to give them fluid?
Please, is it possible
Yeah,
to go back and look at, because it went by so fast that for me, I couldn't.
you want to look at the case a little bit more, right?
Yes,
So we have
yes.
a 100 kilo, 46-year-old male with a past medical history of constrictive pericarditis who had a pericardectomy in the past. He has end-stage renal disease on hemodialysis. He is status post a video-assisted thoracoscopy for empyema, and he presents to the ICU postoperatively for sustained hypotension and hypoxemia in the immediate postoperative period. He's intubated and sedated. He has significant pulse pressure variation. He's modeled in his lower extremities, and he has poor capillary refill. His chest tube is to suction. It is tidally. He has serosanguinous output and has a minor leak in his chest tube. His lactate is 6, and his intraoperative fluid balance is positive 1.5 liters. And postoperatively, when he arrives to the ICU, he receives a 20 cc per kilo bolus of isotonic fluid resuscitation. And the question is, utilizing critical care ultrasound for assessment of this patient, first you want to have a differential, but what would be your approach? And, I'm having trouble with a lot of the connection. I'm not hearing you guys very well. So I'm going to kind of just talk about the differential and we'll move forward, okay? So the differential diagnosis is really broad in this patient. As you probably know from post-surgical patients, you may see things in every category of shock, including hemorrhagic, hypovolemic. You may see things like obstructive shock, pulmonary embolisms, hemothorax, pneumothorax, things like pericardial effusions, any combination of cardiogenic dysfunction, whether it's valvular or myocardial, and obviously post-surgical sepsis, anaphylaxis or any type of distributive shock, it's definitely on the table. So the differential is quite wide, and it's therefore very difficult to have a very directed approach to these patients. However, ultrasound can help us quite a bit. Before we really get into that, we really need to understand the complex physiology interactions between the respiratory and cardiac systems. Basically, alterations in intrathoracic pressure are transmitted to the heart and lungs and can dramatically alter cardiovascular performance, with significant differences existing between physiologic response of the right and left ventricles to changes in intrathoracic pressure. It is critical to keep in context because positive and negative pressure ventilation and how their effects on patients' cardiovascular physiology differ. During the inspiratory phase of negative pressure ventilation, for example, intrathoracic pressure becomes negative, and therefore the pressure gradient between the right atrium and the venous system is significantly higher, which increases blood flow and leads to higher volume in the right ventricle, leading to a leftward deviation of the intraventricular septum. This leads to a smaller left ventricular cavity size and a smaller stroke volume that is happening concurrently with the inspiratory part of the respiratory cycle. Conversely, during positive pressure ventilation, that relationship is actually backwards. Therefore, it's important to understand that during negative pressure breathing, you may have a collapse of the inferior vena cava, and during positive pressure breathing, you may have a distension of the inferior vena cava. Additionally, the inspiratory phase will cause a decreased cardiac output during negative pressure breathing and an increased cardiac output during positive pressure ventilation. So these are really important to keep in mind because many of the studies that we'll review differ in their patient populations. Some have positive pressure ventilation as a dependent factor for their patients. Some have negative pressure ventilation, and those especially are the earlier studies for ultrasound assessment. In any case, so outside of ultrasound, what are some modalities that we assess for intravascular volume? These are common things such as utilizing blood pressure and heart rate correlations, looking at urine output, looking at labs like lactate, pulse pressure variation, which is a waveform of the arterial waveform. You may see a very different peak and trough. And if the peak and trough of your systolic blood pressure is significantly different between inspiratory and expiratory phase, that could give you a clue of a hypovolemic state. However, that's not perfect. Obviously, using a pulmonary arterial catheter and thermodilution can be really helpful to understand cardiovascular physiology. And more recent devices like the Vigileo and the FlowTrack can use pulse contour analysis for estimation of stroke volume variation. I don't know if you guys have access to these devices, but they're these non-invasive ways of kind of gauging whether or not somebody needs a fluid or not. They all have their limitations, but they are available at times. Now, what about ultrasound assessment for volume responsiveness? With ultrasound assessment, we can look at the inferior vena cava, we can look at the superior vena cava, we can look at the left ventricular outflow tract maximum velocity of blood flow. We can look at stroke area, left ventricular and diastolic area. But really, ideally, dynamic ultrasound variables, response to passive leg race or fluid bolus, those are really the gold standard to evaluating whether or not somebody is going to be fluid responsive. We generally define somebody that has a response to blood volume, or we'll call it volume expansion, as somebody who increases their cardiac output by 12 to 15%, depending on what literature you read. Before we move on, I want to briefly make sure everyone understands how to interpret the area under the curve graph, also referred to as a receiver operating curve. When critically evaluating a test to determine if the data is likely to be correct, we frequently use an area under the curve graph that depicts the probability of an assessment being a true positive versus the possibility of the assessment having false positive results. Based on the curves below, what curve do you think depicts the best quality test? I'll leave that open for a response here. You guys can hear me okay, correct? I think I see something in the chat. B, yeah, that's right. So B is a representation of a test that has a very high true positive rate, which I'll highlight here for you guys. So if you set your variable, say your cutoff for ultrasound assessment of volume status to be on this part of the curve right here, you're going to have a very high true positive rate and a very low false positive rate. As you increase that that sensitivity, you may decrease your specificity if you move on this part of the curve, with the difference being that if you have a 50-50 shot, no matter where on the curve you move, your false positive and true positive rates are 50% each. So that just kind of highlights how you can utilize these area under the curve graphs to interpret some of the literature we'll look at. So let's talk about the evidence on the use of ultrasound to evaluate volume responsiveness. The guidelines for appropriate use of bedside general and cardiac ultrasound to evaluate critically ill patients provide recommendations on the ventilated patients, while not providing very many recommendations for the non-ventilated patients. What you will see is that for ventilated patients, you want to have a 8 to 10 cc per kilo tidal volume in a ventilated patient, right? You want to make sure that their normal sinus rhythm, they have a normal right ventricle, they have a normal end diastolic diameter and area, and they don't have any ventilator dysynchrony. They want to make sure that they're synchronous with the vent, their heart rate is normal, that they have normal cardiac function without any arrhythmias, and that you're ventilating them with 8 to 10 cc's per kilo tidal volume. In the non-ventilated patients, there's very few guidelines to really guide whether or not somebody's going to be fluid responsive and to validate the test, other than if you have a dynamic measure like a passive leg raise or a 250 to 300 cc fluid bolus that is giving it as a part of a fluid resuscitation, you should see an increase in your cardiac output by 12%. One thing that's really important is if you have abdominal pathology like intra-abdominal hypertension, or in pregnant patients, these numbers don't really make sense and you can't really interpret this literature in that context. So one of the first studies that we'll review is actually a cardiologist-driven study. Kershaw and his group of cardiologists were the first to publish on inferior vena cava collapsibility and its ability to predict central venous pressure. Importantly, this case was done in spontaneously breathing patients. The measurement was done within 2 centimeters of the atrial cable junction. So when you look at the infrahepatic or intrahepatic inferior vena cava, and you assess the cava at the level of where it's meeting the right atrium, you want to be within 2 centimeters of that atrial cable junction for this measurement to be as accurate as possible. The authors report a cable index, which in more recent literature has been termed collapsibility index. A collapsibility of greater than 50% indicates a right atrial pressure that is less than 10 millimeters of mercury. and a collapsibility of less than 50% indicates a pressure within the central venous system of greater than 10 millimeters of mercury. It's critical to understand that in this study, inferior vena cava evaluation is in spontaneous breathing patients, and it was used to approximate right atrial pressure, which is not necessarily a volume. They are related, but they're not linearly related. So it's one of the first studies, and therefore it's permeated the literature and the practice of clinicians to evaluate inferior vena cava for collapsibility in spontaneously breathing patients. However, it's not clear how valuable that is, and we'll review that here in the next few slides. Okay, so in the ventilated patient, Barbier and his colleagues in 2004 studied septic mechanically ventilated patients, and they were assessed for volume responsiveness. They received a 7 cc per kilo plasma expander, and they had a 15% increase in cardiac output as the cutoff value where they deemed a patient to be responsive to fluid. They used a threshold of greater than the 18% distensibility of the inferior vena cava. Now remember, these patients are being ventilated, and therefore it's not a collapsibility index, it's a distensibility index. What they found is that in their small study, you're talking about only 23 patients, there was a 90% specificity and a 90% sensitivity to pick up patients that would be volume responsive. Of course, small studies are fraught with errors, Hawthorne effect and all sorts of other errors associated with small studies. So you can't really buy too much into the 90% specificity and 90% sensitivity for a study this small. However, those are the numbers that they reported. And you can see here in the receiver operating curve, we'll say the optimal location highlighted by my laser pointer shows that representation of the distensibility of the inferior vena cava in these patients showed a 90% sensitivity and 90% specificity. You can see that they compared that to central venous pressure, which was about a point slip, whether or not you were able to discern if a patient was going to be volume responsive purely based on central venous pressure. A following study by Faisal in 2004 had 39 mechanically ventilated patients where they received 8 cc's per kilo of a volume expander. Volume responsiveness was defined as 15% increase in cardiac output, and they determined that a distensibility index of greater than 12% allowed for identification of volume responders with a positive and negative predictive value of 93 and 92% respectively. Of course, this study also is fraught with error given the size of it. However, they had similar results, and therefore it supported this use early on of ultrasound for evaluation of patients that would be fluid responsive. You can see that during mechanical ventilation and positive pressure ventilation, during insufflation, you have a distension of the inferior vena cava, and that's how they calculate this distensibility index. You take the difference between the maximum and minimum, and that allows you to calculate this index. In any case, I'm going to stop there just to give you guys a second to see if you want to ask any questions about this particular measurement. What I will do is I will move on, and if you have any questions, just throw them in the chat, and as I move through, I'll check periodically, okay? So unfortunately, in our post-surgical patient population, it's very difficult to get a subcostal view Subcostal view would be in this epigastric subxiphoid location, which is the classic place where you would evaluate for inferior vena cava size and distension during mechanical ventilation. Generally, many post-surgical patients will have incisions or dressings or chest tubes, especially if they had cardiac surgery, that are going to be in that location, and therefore an alternative is what is shown here on the lateral aspect of the patient. You can get what's called a right lateral ultrasound view of the inferior vena cava. A group led by Shah and colleagues examined the validity of transhepatic approach to evaluation of the inferior vena cava collapsibility index and spontaneously breathing patients. Remember, spontaneously breathing patients, which is different than what we just saw. They used a 42% collapsibility as a cutoff to predict fluid responsiveness. Importantly, transhepatic and subcostal measures are discordant, where transhepatic measurements underestimate subcostal inferior vena cava collapsibility. Therefore, the authors recommended that if the transhepatic collapsibility is greater than 42%, it can be used to rule things in, meaning the possibility of fluid responsiveness can be ruled in. However, it cannot be used to rule out fluid responsiveness. Unfortunately, if you look at their receiver operating curve and you use this ultrasound measurement, it doesn't look like you would be very successful. You're almost better off flipping a coin and deciding whether or not to give the patient fluid. Much later, in 2017, Vignon and his colleagues looked at a comprehensive review where they evaluated ultrasound indices to predict fluid responsiveness in ventilated patients. Remember, this is in ventilated patients. They had 540 mechanically ventilated patients with acute circulatory failure. They basically did not discriminate between shock states. They just wanted to see in general circulatory failure, hypotension, whether or not all these different indices would be helpful to evaluate whether a patient would be fluid responsive. The goal was to figure out which patients would have a significant increase in their cardiac output after fluids. They defined this as a greater than 10% increase in cardiac output during a passive leg raise test. A reversible, this is, as you guys know, a reversible maneuver that mimics a fluid bolus by shifting venous return without actually giving fluids. There are several patient populations that may not benefit from fluids when they are hypotensive. You can think of patients like cardiogenic shock from heart failure or severe pulmonary hypertension with volume overload. These patient populations would likely deteriorate rapidly if you were to give them fluid, and therefore a passive leg raise is a really good alternative. So what they found is, as the cohort that they studied, 42% of patients were fluid responsive. To predict this, they used echocardiographic measurements for dynamic parameters that reflected how respiration affects hemodynamics in ventilated patients. They utilized a non-ultrasound measurement, pulse pressure variation, which we mentioned earlier in the presentation. And it turns out it's actually for a minimally invasive kind of continuous measurement that you can get with an arterial line, it's actually quite good compared to some of the other measurements that they tested, especially if you compare it to looking at the inferior vena cava size and its change. If you look at these two graphs, the pulse pressure variation just from having an arterial line was performed better than your ultrasound assessment of the inferior vena cava. In any case, they also evaluated some more advanced measurements. One of the most valuable ones that they found is the variation in maximal aortic velocity of blood flowing through the left ventricular outflow tract. And what they found is that during respiration, you have a peaks and troughs of blood flow going through the left ventricular outflow tract. This measurement specifically, the one being highlighted, had the best sensitivity to discern patients that may benefit from fluid resuscitation. The last measure that they looked at was this change in superior vena cava size. Unfortunately, this measurement cannot be done without a transesophageal echocardiogram. However, it turns out that it is the most specific for patients that may benefit from fluid resuscitation. Basically, if you were to conduct the perfect ultrasound assessment and had access to a transesophageal echo, assessing these two values would give you the highest sensitivity and specificity to try and figure out what patients would benefit from a fluid bolus. Okay, so we talked a little bit about some more static measurements. The most important thing, and something we measured earlier, is to really understand dynamic measurements and how those dynamic measurements can be interpreted. So we'll see a couple studies. One of the better studies out there, and one of the earlier ones in 2001, examined how the patients responded to a fluid bolus of 8 cc's per kilo during, and they evaluated the blood flow through the left ventricular outflow tract during that resuscitation bolus, basically before and after. And what ends up happening is you can see this change that happens between the variability of before the fluid bolus and then after the fluid bolus, where there's much less variability in the flow through the left ventricular outflow tract. This is analogous to the prior slide where we saw the most sensitive measure was doing this exact maneuver. In the prior study that we reviewed, they utilized a passive leg raise. In this particular study, they utilized a 8 cc per kilo bolus. And what they said is that if there was a 12% change in the variability, it predicted a 15% change in cardiac output associated with volume resuscitation. These patients who received this treatment or this evaluation had, according to their small study, which was only 19 patients, had 100% sensitivity and a 89% specificity. A much larger study that was done in 2006 was the first to use aortic blood flow as a response to passive leg raise. And this study had a little bit more attention in the worldwide critical care ultrasound literature because it was one of the largest studies published at that time. Basically, they looked at 71 mechanically ventilated patients. They looked at pulse pressure variation, and they looked at aortic blood flow through the left ventricular outflow tract. And what they found is that the passive leg raised and the blood flow through the outflow tract had a much superior passive leg raise response to being using this assessment, having a 97% sensitivity and 94% specificity as compared to a much lower sensitivity and specificity as seen by the passive leg raise. Now we come to one of the most recent studies where they had a very similar but more true life approach to, we'll call it a pragmatic approach to their trial. In this case, a very recent paper in 2020 where they evaluated fluid response in septic hypotension and shock. It was a randomized trial, and it was a multi-center study tackling how to manage fluids and vasopressors in patients with septic shock. The big question was whether or not using dynamic measures like checking stroke volume, changes during a passive leg raise could guide resuscitation better than standard care and improve outcomes. Passive leg raise, as you guys have seen, is a simple test where you lift the legs see if the blood flow in the heart increases enough to suggest that they benefit from more fluids. They ran their trial across 13 hospitals in the United States and the United Kingdom, and they enrolled patients with sepsis-related hypotension who were admitted to the ICU. The intervention group, which was 83 patients, got their fluid and vasopressor treatment tailored based on passive leg raise, while the control group got usual care, which did not include ultrasound assessment or the passive leg raise. The main thing that they tracked was fluid balance, basically fluids in versus fluids out at 72 hours or intensive care unit discharge. Basically what they found, and this is seen here, is that the fluid balance for the intervention group was substantially lower at a p-value of 0.02, where the intervention group had an average of 0.65 liters of fluid compared to 2 liters in the usual care group. Interestingly, their secondary endpoints had substantially lower renal replacement therapy needs and substantially lower ventilator days for these critically ill patients, which suggests a substantial benefit. To date, this is one of the larger trials that has really evaluated ultrasound assessment of blood flow through the left ventricular outflow tract during passive leg raise as a pragmatic kind of approach to guiding resuscitation in these very sick patients. So, you know, out of the studies that are currently out there, that's one of the most impressive. So we're going to stop for a little bit of a knowledge check because we've covered a ton of information. So our patient is ventilated with 8 cc's per kilo. He has neuromuscular blockade and sedation. Considering the measures that we've reviewed, we need guys to kind of decide which measurement type is going to best discern with the highest sensitivity and specificity that a patient may be responsive. What was that? You guys can just put it in the chat, which you believe to be the best approach to this. And to be quite honest, all of these answers may be appropriate. However, some might be better answers than others. So I'm going to run through each one of these because I think it'll be helpful. The inferior vena cava distensibility of greater than 45% would be a patient that's likely going to respond to fluids. However, if you remember looking at the receiver operating curve or the area under the curve, it was not great, especially for the better studies, with only about a 60% likelihood of being correct. A passive leg raise with a change in your maximum velocity of flow by 12% would suggest a patient that is likely going to be fluid responsive. However, that static measurement without looking at variability is a little bit less beneficial. Looking at just increased mean blood pressure by 10 millimeters of mercury after a fluid bolus of 250 cc's would be a non-ultrasound assessment way of seeing if the patient is responsive. However, the general thought is that that's going to be less likely. And then D is probably the most likely to be the correct answer because this is incorporating both a variability measurement and a passive leg raise with an increased 15% cardiac output. So that would tell you that this is likely the right answer. Okay, so the real question though is, sure, we can give people fluid, they might be fluid responsive, but can we cause them harm? So there's a concept that was introduced by Nair and Southoff in 2019 that proposed the term of fluid tolerance in an analytic review. Even in fluid responsive patients, you may still harm that patient. let's just say they've had progressive pulmonary edema or organ dysfunction because of venous congestion and interstitial edema. If a patient is harmed by fluid administration, they're termed to be fluid intolerant, and individualizing fluid resuscitation to avoid clinical bulimia is postulated to be important. This was followed up by protocols. This was the Falls protocol that basically incorporates lung ultrasound. This is published by Liechtenstein. It incorporates lung ultrasound to evaluate if a patient should receive more fluid. As you guys may or may not be aware, during lung ultrasound, if you have a A-line profile initially, which is these horizontal lines on ultrasound assessment of the lung, you don't have significant fluid overload. However, if that profile changes to these comet tail-shaped lines called B-lines, you may have a patient that now is developing substantial pulmonary edema, and even though they may benefit from fluid resuscitation, I think in that case, the fluid resuscitation may be more harmful than good. You may have a kind of concurrent scenario where patients are likely to be fluid responsive, but also likely to be fluid intolerant. And that's something that's really important to discern. But what about scenarios where the patient has, for example, trolley, pneumonia, ARDS? Those lungs are going to be very difficult to evaluate because those patients will develop fluid in their lungs that is maybe inflammatory as opposed to just fluid overload related, in which case those measures of looking at the lung with ultrasound to determine if someone can receive fluid may not be helpful. Therefore, an alternative that was developed by a group out of Montreal, led by Bouillon, basically showed that looking at extrathoracic ultrasound, looking at the liver, looking at the kidneys, and looking at the portal vein may be helpful in discerning whether or not somebody has clinical hypervolemia and may not benefit from fluid. What you'll see is that utilizing pulse wave Doppler ultrasound in the hepatic vein yields a classic waveform, with the S wave being more prominent than the D wave. This would be the normal on the left side of the screen. And then when somebody starts to reach hypervolemia, you may see a abnormal waveform, which shows what we refer to as S and D inversion, where the D wave becomes more prominent. In the same token, you may see the portal vein has a change in its waveform assessed in its pulse wave Doppler assessed waveform. The classic waveform is laminar flow, as seen on the left side, with this constant flow through the portal vein. When a patient becomes fluid overloaded, you may see this more pulsatile flow through the portal vein, which would be pathologic. So I want to go back to our initial case. We'll review it a little bit. We'll pause for a second and kind of understand how you might go about it with all this information that we've learned today. So a patient that is 100 kilos, he's 46 years old, he's critically ill, he's immediately post-operative, and he has a lot of reasons to essentially be hypotensive. It's very much an undifferentiated shock. I'm going to pause here for a second, let you guys kind of read what is on the screen, and then we'll move forward. This is nothing new from the case that we reviewed earlier is in here, but it's something that I want you guys just to have fresh in your mind. Okay, so let's look at some of the ultrasound-derived measurements that we've gotten from this patient's evaluation. So this patient's maximum velocity through their left ventricular outflow tract is greater than 20%. That's concerning. That might mean that this patient may be fluid responsive, but let's do a little bit more digging here. Passive leg raise does not change how much variability there is. This may mean that the patient is so fluid under resuscitated that maybe in this case, the patient needs much more than 300 cc's of auto transfusion for the variability to decrease, or he may have another pathology. You see with lung ultrasound that he has some B lines in the mid-axillary and lower regions, but none are anteriorly, which kind of supports that this patient probably could receive fluid. However, he does have a small pleural effusion on the surgical side and a small apical pneumothorax on the surgical side. This would not suggest any sort of pneumothorax or hemothorax, therefore that's probably off the table. The inferior vena cava does not distend greatly with positive pressure ventilation, and the distensibility is way less than 18%. You may see this more in the 5% range, but barely distensible. And then what you do is look at the organs, the abdominal organs, and you see that their portal vein flow has intermittent kind of pulsatile flow, and the hepatic vein flow has SD inversion, suggesting volume overload. Additionally, what you see is the right ventricle and the left ventricle ratio is 1:1, which would be an abnormal relationship. So what do you guys think is going on here? So clearly this patient has kind of a undifferentiated reason why they're hypotensive, and kind of information that doesn't really come together, right? Some of the information is telling us maybe the patient needs more fluid, and some of the information is telling us that maybe this patient is fluid overloaded. So I think we need to look a little bit more. So what is the diagnosis? Let's look at each thing. So on the right side of the body, when you're looking at the right-sided circulation or the venous circulation, you see that you have the hepatic waveform, hepatic vein waveform that has SD inversion during the inspiratory phase of positive pressure ventilation, which suggests volume overload. You're also seeing this pulsatile portal vein waveform, which suggests a substantial volume overload and a pathologic volume overload. On the lung side, especially the anterior fields, you're really not seeing significant volume overload. So there's a bit of a unknown here. The lungs don't have excess fluid anteriorly, and therefore it's a little bit confusing. And on the left side of the circulation, on your arterial side, you have substantial variation. You can see the maximum velocity through the left ventricular outflow tract is substantial in its peak and trough relationship of probably about 20% difference, in which case that would suggest a patient that has hypovolemia. Now, we have to remember that the patient has, when you have right-sided and left-sided measures that don't come together very well, it may suggest that there's a problem with the heart itself. In this case, the patient has this D-shaped septum and a 1:1 ratio between the right ventricle and the left ventricle. This suggests a right ventricular failure, and that goes back to the discussion of really understanding the relationship between the cardiopulmonary blood flow and how positive pressure and negative pressure ventilation differs, and how that intraventricular septum may cause your ultrasound values to not really make sense. I went through this case for a very specific reason, and it's because when you have substantial changes in your right ventricle that causes intermittent decrease stroke volume from your left ventricle because of the intraventricular septum component, you may see this very confusing picture that looks like volume overload on the right side of the heart and need for volume resuscitation on the left side of the heart. And really what I'm trying to get at is if you were to only evaluate the left side of the heart, you may think that this patient needs volume. If you were only look at pulse pressure variation, for example, from an arterial waveform, you may believe that this patient needs to receive more volume. If you were to look at a pulse contour analysis, like is seen on a flow track or a Vigileo system, it may tell you, hey, this patient needs volume. But in this particular patient, giving them more fluid may actually cause them harm, and most likely would. So here are the take-home points. Critical care ultrasound is a diagnostic and monitoring tool. It must be interpreted within the clinical context of the patient. The critical care ultrasound must be done in a systematic approach so that you don't miss seeing this situation where you think that the patient needs volume and then you end up hurting them. And clinical hypervolemia, you need to assess both fluid responsiveness and tolerance. It's really, really important. And I think that it's one of the things that is often missing from people's assessment. So I have a ton of resources that are on my references, and also my contact information is available. I'm happy to take any questions. And again, I thank you guys so much for bearing with me. My voice is leaving me. But thank you so much, and I'll take any questions.